Good morning, everyone. We're just going to keep on rolling through here to keep on schedule. Um, my name is Matt Stenzel, and I'm with Front Range Clinic, and I'm one of the organizers of the Supar short event. We're fortunate to have with us Dr. Michael Barnes. Dr. Barnes is a master addiction counselor and licensed professional counselor. He's spent the past 3 years as the chief clinical officer at the Foundry Treatment Center here in Steamboat Springs, where he provides administrative and clinical oversight for all residential and outpatient programs. Dr. Barnes came to the Foundry after serving for 5 years as the clinical manager of residential services at CEDAR, or the Center for Dependency, Addiction, and Rehabilitation at the University of Colorado Hospital. He also spent 10 years as a full-time clinical professor in counseling. Most recently, he served as the clinical coordinator and clinical associate professor in the master's program in counseling at the University of Colorado, Denver. Dr. Barnes has developed trauma-integrated clinical models for the treatment of individuals with co-occurring addiction and trauma, and he speaks nationally on families, trauma, and addiction. In his free time, Dr. Barnes is an avid road cyclist, beginner mountain biker. He also enjoys skiing, hiking, camping, fishing, Colorado Rockies baseball, and Florida State football. As a native of Hollidaysburg, Pennsylvania, he also enjoys following Pitt football, Pittsburgh Steelers, Pirates, and the Penguins. Thanks for joining us, Dr. Barnes. We need to unmute you, Dr. Barnes. There you go. There you go. We got you now.
Okay, thanks, Matt. I was just saying that I'm really happy to be back. I had the good fortune to be able to speak last year more on family issues, and this year going to try to, trauma is such a big thing right now, and my goal is to try to really focus on how can we do this in a way that doesn't require significant funds. And so often we think of trauma working on the actual trauma memory, and there are different phases of working through traumatic stress issues. And so I'll kind of talk my way through that process. If we can go to the next slide. So when I think about trauma-integrated addiction treatment, so the first time when I was at the university as a professor, I had been really working on some models of looking at how do we integrate that there are so many similarities and these sort of crossing of paths in terms of symptomatology for clients who are in 2013, I think I did my first national presentation on that subject, and we were still really in the process of talking about trauma-informed versus trauma-integrated. And so over the next hour, I really want to talk about how do you really do it from an integrated standpoint. And so the work is to work simultaneously with the symptoms of addiction, chemical dependency, process addictions, and the daily symptoms of post-traumatic stress or developmental trauma, secondary trauma, etc. And developmental trauma is typically associated with, so if PTSD is what are the things that happened to us, developmental trauma is typically seen as what are the things that weren't done for us? What are the things that we did not get? Did we live in a family with significant abandonment, neglect, things like that? And secondary trauma is what happens in family systems. And that's really been my area of research and study over the years. And that in most cases, families report more experience of trauma than actually our clients do in most cases. So when I think about this model, I think it's really critical that we look at the kind of the realities of the implications of culture and race and gender and socioeconomic influence And I tend to look at it as the sort of ecological model, and the idea of, you know, clients from the Front Range may have very different cultural and experiential societal influences than individuals who are on the Western Slope, and really beginning to look at what is the influence of family and family history and the environment that they were raised, and neighborhood and larger cultural issues. And that idea that, you know, while addiction, the disease, the chronic disease process may be similar, there are so many different the help seeking process, how families interact with them in that process. And so when I really look at it, I think the last bullet is the most important. It's really the dance between traditional scientific and clinical understanding, more and more kind of work in neuroscience and kind of evidence-based clinical interpretation and clinical work, with client worldview associated with culture, familial history, illness, etc. And so while I am a huge advocate of evidence-based practice, I'm also a believer that one size does not fit all, and that sometimes some of the clinical activities that we would do to help a client manage their autonomic nervous system or to develop regulation skills may be outside of that kind of purview of evidence-based practice. Next slide, please. And so when I think of trauma, I always speak about the need to expand our range in understanding what we're dealing with. And so when I mean trauma integrated in terms of as a person who has experienced a significant amount of trauma in my own life, have I done my own work as a therapist? Has our admissions team done their work? Do they understand this idea of, you know, basic trauma symptomatology? And it's interesting, when I was a professor at CU, I had a student that said, she raised her hand in a class and she said, so what's the best way to worked with an unmotivated client? And at the time that question, after I said that, the class laughed, and I'll tell you, I have told this story 100 times at conferences, and when I asked, has anyone in the room ever worked with an unmotivated client, they all laugh. Everyone starts to laugh, like, well, of course we have. And what I really want to kind of, what I said to my student, and the same thing I will say to you, and that is that most of my clients are incredibly motivated to stay safe. And that if we can understand that, anyone who comes to us with addiction and a primary trauma, kind of a nervous system that has been evolved, and a limbic system that has been, in my terminology, injured through the trauma process or shaped through the trauma process, what we typically call unmotivated or avoidant, in most cases, is very clearly an attempt to stay in control, stay as safe as possible. And when we begin to look at that process, there's a completely different feel when I can begin to look at a client who isn't participating in treatment, who tends to be rough and avoidant, to kind of keep in mind that these are exactly the symptoms of primary trauma, and that if we can begin the process of working with that person. You know, the other thing that's really interesting, and I say this all the time to our staff, like, tell me again why we're so upset with a traumatized client acting like a traumatized client. And Dan Griffin, who has written many books on men and addiction and trauma, and I have talked many times that so many men who are struggling with this foundation of trauma, who tend to be defensive and at times aggressive, often get discharged from traditional addiction treatment because of those behaviors, and they get discharged for acting like a traumatized client. in that process. The other thing is the idea of family compassion fatigue. We as healthcare workers are very susceptible to that kind of relationship, that interrelationship between burnout, working in a highly stressful environment, particularly in the days of COVID, and the idea of secondary trauma, that we get vicariously traumatized by our work with the trauma narratives that we hear. And then the last is the organizational trauma, the idea that if we work with so much trauma and we don't pay really attention to the shifting organizational rules and roles and needs, that we can often have a compassion fatigued organization as well. So if we're going to truly be integrated, it's not just clinically, it's in our hiring, it's in our training, it's in our the safety that we provide in our treatment environment. Next slide. I'll go very quickly on this, but I was asked one day, so how much trauma is there? And I said, well, I think we have a traumatized society. And someone asked me to explain that. And so I went back and I looked at the numbers. And if you look at the numbers on this page, that on any given day in the United States, all of the things that I'm talking about happen. 43 people were murdered. Every one of those people has a family. The person who murdered them has a family. That it begins to impact. And again, in my dissertation research, I coined the term systemic traumatic stress to represent how families begin to adjust their organization around the trauma rather than when they don't know what to do about it. The number of rapes, 2,200, very moderate estimate, 123 suicides, opiate deaths. The ones that tend to get kind of missed are things like diagnoses of cancer. There's some significant research findings out there that talk about not only the trauma experienced by the person who has been diagnosed, but also by family members and how relationships within the family change, triangulation between the family system members, enmeshment, disengaged kind of process. So if you look at those, cancer, heart disease, it's not unusual for me to ask a client, do they have a trauma history? And for them to say, no, I've never been sexually abused. But when we begin to go into some of these other things, how many people do they know who have overdosed? Have they ever been in the presence of someone who has overdosed? Friends that have died from car-related crashes, how many times they've been to emergency rooms. So as we begin to look at clients, I'm of the opinion that trauma integrated work is kind of like universal precautions, like we would do with any kind of infectious process. And the idea that we kind of assume that people have some element or some history with traumatic material and treat them from the admission process forward in a way that is respectful and safe and trauma informed. The next slide, please. So I really see a difference between trauma-informed and trauma-integrated, and I think trauma-informed is primarily a kind of a relational and philosophical foundation for working with patients and clients. It's really a necessary component. Is our environment safe? Do our policies and procedures avoid the re-traumatization by limiting people's treatment options, limiting people being able to experience the symptoms that they're supposed to experience? And so while it is necessary, it does not really speak to what would trauma integrated work look like. And I've really looked around a lot and I've talked to a lot of people, and how I developed this presentation actually 2 years ago was the idea that when I talked with a number of people from around the country, no one had the same philosophy or no one had the same definition of what trauma integrated work is. And so I really started working with the Foundry clinical team on, let's develop a truly clinically appropriate trauma integrated model, and that this presentation actually became like kind kind of a model of not to do the same thing, but to show individuals who are interested in developing trauma integrated work what it could look like and what are the components of it. It is my opinion that we can do trauma integrated work without ever doing EMDR, without ever doing somatic experiencing, without doing any of the really trauma specific treatment models. And I say that because in 1992, Judith Herman wrote a book called Trauma and Recovery. And it was the first book that I ever read on trauma. And I had just gone back for my doctorate and was working with Charles Figley, who was one of the top traumatologists in the country. And that was the book that he told me to read, it's the state of the art at that time. And it will give you a framework for the clinical work with traumatized clients. And it's a 3-phase process. First is safety, and really working on autonomic nervous system regulation, the development of coping skills, the reduction of dangerous symptoms and coping strategies. And it's my opinion that we have a detox, we have a residential program, we have a partial hospital program that's sort of a merger of residential and outpatient. And then we have an IOP, or an intensive outpatient program. And so trauma integrated means that it's not just in the residential program, it is integrated across all of our levels of care. So someone could actually be with the Foundry for anywhere from 4 to 6 months. And so that idea of the communication between the staff of different programs, the articulation of a very clear clinical model. And so in the earliest phases, all we're going to work on is safety. We're not going to be opening the door to working on significant trauma memories unless that really pops up, or that in talking about core recovery needs becomes an issue. And in that case, we're going to then begin to use some more trauma-specific treatment. But we don't have to do that. If the person does not identify those trauma memories. And I'll talk a little bit about the neuroscience of post-traumatic stress as to how that system works. Next slide, please. So when I say safety, again, the safety is the environment being safe from substances, dangerous relationships, extreme symptoms, the monitoring for suicidality, fully aware of the full sympathetic and parasympathetic nervous system response, a warm, supportive, and empowering setting. And so that idea of talking to my staff about, tell me again why we're upset about a traumatized client acting like a traumatized client, is really speaking to that idea of, our clients are actually assessing us far more than we're assessing them. And if we think about Porges and the polyvagal theory and the relational, the attempt to work through the evolutionary process of the different defense mechanisms with relational skills first, and then fight, flight, and then dissociative process, clients who are with us typically are not very good in the relational skills area and are very highly defended either through fight, flight, or freeze. And so how they assess us in the very first meeting actually can set the tone for a truly successful treatment environment, or particularly with clients that are very avoidant attachment, the idea of writing us off fairly quickly and a client leaving against medical advice. And so I wrote an article in Addiction Professional magazine on the first session in psychotherapy and addiction and the critical nature of that. And it's really speaking to this issue of safety and engaging clients in that work. And again, we can say that a client who is highly motivated to stay safe is avoidant, but it's our job in a trauma-informed or trauma-integrated model to figure that out and to begin to engage that person. Safety, that we've all done our own work, the idea of I have a lot of trauma, I have done my work, as always, have lots of work to do. What is our own attachment skills, countertransference reactions, how much compassion fatigue do we have? Do we offer the ability for our staff to kind of work through some self-assessment? I just finished a video that is a training video for our staff on compassion fatigue, what it is, what it isn't, how to cope with it, that I would be happy to share. It's on my YouTube channel. So if you really are kind of looking at how do we do this with our staff, I have ample resources that I would be very happy to share with anyone who's interested, from videos to worksheets to other educational material, because it is absolutely at the foundation of trauma integrated work. Because if we're not safe, the treatment's never going to be safe. Let's go to the next slide. So trauma integrated work also means that all groups in your organization need to be trained, whether it's the CEO, clinical supervisors, and the research would show that those of you who are clinical supervisors are actually at the highest susceptibility for compassion fatigue, because you hear the trauma narratives of every client in your organization. So that idea of when I consult with organizations on compassion fatigue, the first thing I have the organization do is have the CEO or the chief administrator in the organization send a letter to every employee in the company that says, we are a trauma-informed and trauma-integrated treatment environment. We understand compassion fatigue, and that we're going to provide you with resources to make sure that you get these. And they don't have to be huge, expensive resources. And again, that's another lecture. It involves all levels of our organization, from our admissions team to nursing, our kitchen staff. Our chef is in the process of taking coaching classes, because so many of the clients will be sitting in the kitchen and dejected or frustrated, and that they tend to go to him not for therapy but for support. And he's really beginning to recognize that in this trauma integrated work that we're doing, that he's every bit as important as the therapist is. And I will say, who spends more time with your clients than support staff, techs, family educators, kitchen staff. And so this cannot be just a clinical model. It has to be a model that kind of weaves its way through the entire organization. So the Roger Fallett's comment from 2011 involves making trauma-informed changes into new routines, new ways of thinking and acting, both understanding and practice. And the idea is, if we train everyone and they're very clear on what we're doing, and we're mindful of these consistently new rules and routines, that it will become normal, that it won't, and at Foundry at this point, it's very normal. We don't, there isn't a discussion about this client has trauma. There's this understanding of these are the symptoms that this client exhibits that are trauma related, but also associated with their addiction. Okay, next slide, please. I'm going to go through the family stuff fast, but my PhD is in marriage and family therapy. I have worked with many, many traumatized families. When I was at Cedar, we did a research study and found that we asked over 300 family members, we asked a lot of questions, but one of the questions was, is living with a actively using addicted family member traumatizing. And 75% said that it was that they strongly agreed, and then another 20% said that they agreed. So 95% of all the family members that we worked with said that they had been traumatized just by living with and trying to cope with the active addiction of a loved one. And so what's the importance of that? Well, if they are indeed traumatized, they have the same autonomic nervous system response as any other traumatized person. So we begin to look at things like enabling. And if you talk to any family member who enables and lay out the scenario, they will talk about the fact that when that person walks in the door and they know they're going to ask for rent money, their heart starts to race and their pulse goes up and their chest tightens and they start to experience a fight-flight response. And they know that if they follow the therapist's recommendations of not enabling, that the person's going to be angry and there's going to be a conflict, and that they respond by saying, okay, here's the money, this is the last time. But, and so I always say that telling a family member to stop enabling is like Nancy Reagan telling an addict to just say no. It's without teaching someone how to do that. It's really not very helpful recommendation. And so if we have family members who are traumatized and clients who are traumatized, and most of the families that I work with very typically say, I just wish my loved one would get sober so we could go back to normal. And they tend to forget just how normal has changed as the addiction has advanced. And I will often use a picture of Jelinek's curve to show the progression of the symptoms of addiction and how the family is slowly, gradually adjusting to each of those. And by the time the person gets to treatment, they're usually pretty organized around that problem. So if our family program, if our clients are going to be successful, our family program has to be trauma integrated as well. Next slide, please. And again, sorry for the blurry picture of the genogram, but you know, family experts are really beginning to look at this idea of how do families create normal. And they do it across 3 generations. And so there's more and more information on epigenetics, the idea of that genetic predisposition and how the environment that the client lives in kind of impacts how the DNA is either activated or deactivated. What happens if our parents grew up in very highly traumatized families in which they have avoidant attachment or anxious attachment? And the idea that parents can't give kids what they don't have. And so as parents are being asked to participate in the treatment process, to begin to look at their own issues and to begin to look at family healing, you know, these are the things that are on the right-hand side of the slide that they may have experienced as well as the client may have experienced that will actually get in the way. And so I do, on my YouTube channel, there's also a video that we use with families when their loved one just comes into treatment or is just entering the treatment process. That if you want to, you know, if you would find value in that, please go and check that out. And it's really helping families begin to recognize the need for family healing and all of these influences that we're talking about. So let's skip 2 slides if we can. So this is the criterion A of DSM-5, how people get traumatized. And I'm going to tell you a very personal story as we go through this. And this personal story is that when I was in my first year at Florida State, I have a 34-year-old son. He's an attorney. He lives in Florida. He's doing great. But when he was 5 years old, he ran after a ball that he was playing with in the driveway and was hit by a car. And he broke his femur in half and split his liver almost in half and split his kidney kind of from top to bottom down one of the sides. and he was he was thrown about 30 feet and landed on a red ant pile. And if you're familiar with red ants, he laid on that pile until the ambulance came. And so he was severely bitten by these ants. And so when we look at how people get traumatized, I'm going to walk you through how a family gets traumatized. And so we would say our son meets the first criteria, an individual who has a personal experience of an event that involves threat of death, actual or threatened serious injury, threat to one's physical integrity. Clearly, he was traumatized, and he kind of spent his time working through that. He was in intensive care for 3 weeks, the hospital for another 3 or 4 weeks, body casts, etc. So he had lots of physical things to work through, but then also the emotional things to work through. His mom was standing probably 10 yards away from him when he got hit. And so she watched him fly through the air. She watched him land and be motionless on the ground. And so she witnessed an event that involves death, potential of death, injury, or threat to physical integrity of another person, someone she loves very dearly. Very clearly, in that process, her memory of what happened was different than his. And so different triggers, different kind of memory process, but the exact same symptoms. I was at the clinic where I was all the time. You know, when you're a doctoral student, you're never at home. So you're always at the university. Police officer shows up in my clinic and says, you're the father of this kid. This is what happened. So any individual family member or close associate who learns about an unexpected or violent death, serious harm, or threat of death or injury can experience post-traumatic stress disorder. And so when you think about it, we were all traumatized, but we all had different kind of memories of what happened. And there were different parts of that trauma that impacted each of us. And so our experiences weren't that different, but what triggered our experiences, our disagreements about this happened or didn't happen, were really critical and really important for us to come to terms with in order to heal as a family. And then the last one is the experiencing repeated or extreme exposure to aversive details of traumatic events. Now that was developed for first responders and police officers, but every family who's living with an actively using addict who is advanced in their chronic disease live with repeated and extreme exposure to details of trauma. So the idea that the trauma integrated program is just dealing with this client and their trauma misses the fact that the family is going to need to work through their own trauma in order to be healthy. Next slide, please. So I started paying attention to chronic disease. I found a paper that I wrote in 1991 in a box in my garage as we were moving, and it became really clear to me that in the 30 years since I wrote that paper, not much has changed in terms of family treatment and how we integrate families and clients in the treatment process. So I started looking at how chronic disease professionals in the medical environment begin kind of look at families and how they either help or hinder the process of healing in chronic disease. And this is a model, if we were to take all the trauma stuff out of the middle, that was created by a person, I believe at the University of Cincinnati. His name is Roland. And he talks about there are so many different factors associated with families that are adjusting to a chronic disease that are impacted by how previous generations were impacted by chronic disease, addiction, mental health issues, and other kinds of medical things, and that the previous generations impacted the family members' schemas about safety and about healing and about help seeking, and that in the process, that alters these rules, the 5 R's, rules, rituals, routines, and relationships or boundaries, into how they're going to handle this disease. And the more functional they are, then people are able to move through the life cycle stages and kind of achieve individual development. Well, the less functional, then we have family members who are not moving through life cycle stages, and family members who do not meet individual developmental needs. And in addiction, we often say that the time that the client started using was where they stopped developing kind of emotionally and relationally. And in our model, we kind of look at these same issues, and particularly with our families, and it helps us understand why siblings' issues related to the addiction may be influencing kind of parental response to the illness. And that this is, I say to families, what if this is far more complicated than you think it is? And that your loved one getting sober doesn't necessarily mean you're going to go back to normal. And so with all of the symptoms that are listed in that big black cloud of trauma, that you can see how the addiction is beginning to impact, and the trauma is actually impacting how the family is making its adjustment with the growing addiction. So it really complicates matters significantly in that response. Next slide, please. So if it's about traumatized families, it's also about traumatized professionals. And for time's sake, let's go to the next slide. When we think about compassion fatigue, and we think about how vicarious trauma, or the term chiasmal trauma, impacts the well-being of addiction professionals. Brian Bride and a group of colleagues did a study back in 2009 where he studied 242 NADAC members, National Association of Drug Abuse, Drug and Alcohol Counselors. And the numbers were pretty staggering, and that they found that 19% of, 20% of those professionals that were studied met full criteria for post-traumatic stress disorder. 28% met 2 criteria, and 56% met 1 criteria. And so 43% experienced intrusive thoughts about work, 27% detachment from others, 30% emotional numbing, 26% sleep disturbance, etc. And what they found in a subsequent study was that the higher they scored in terms of secondary trauma, the lower their job satisfaction and the lower their emotion or their occupational commitment. And what they found was the more trauma experience or symptoms that staff were experiencing, the more turnover they had. And we all know what the cost of turnover is, and we all know what how it disrupts our treatment models. And so the idea of, we do a lot of work with compassion fatigue. We offer an employee assistance program. We offer the opportunity for kind of self-care and wellness. We have fitness classes at our ranch. So the idea that we've come to the understanding that if our staff isn't healthy in terms of our own trauma, then clearly they're not going to be able to work with, they're going to be reactive to highly traumatized and difficult emotional and behavioral responses on the part of clients. And so that's critical. Let's skip the next slide and go to the training one. So these are the trauma trainings that we do. We have staff education. I do 5 different trauma lectures for our staff. Trauma 101, that's the continuum, the NAR model, which I'll talk about in a minute. Trauma integrated clinical model, like what are the things that we do, coping with compassion fatigue, and then working with traumatized families. I do 4 different lectures with patients, Trauma 101, childhood trauma or developmental trauma, family trauma, and then how mindfulness meditation is useful for addiction and trauma. We have family education. We do a very thorough trauma assessment. And so there is not a slide for what I'm about to say next, but it's kind of like a trauma integrated model requires the following kind of 4 things. That requires you to identify, document, and articulate a clear model of care. And like, what are the symptoms that you're trying to manage? What are your treatment objectives? Rationale for what you've included in this model. And I'm going to show you ours in a second, but I want to set the tone for that. And then share with clients exactly what the model is and allow them to kind of agree, disagree, struggle, question, why is this the case? I mean, it's not unusual for us to have someone who comes to work for us who is in active recovery. They went to treatment somewhere else, and that they really envision that to be the appropriate model, not what we're doing. So we believe we have to have 100% buy-in from everyone that's working with us on what we're doing and why we're doing it. And that's why we do this level of education and opportunities. We're going to do a tech retreat in 2 weeks because we've made some changes to our model, and we're going to talk to them about that. And we have some new staff. And so I think it's just really imperative that the treatment leaders, and again, not just the therapists. Everyone thinks that the magic happens in individual therapy. And I've been around 35 years, and in my early years, we didn't do very much individual therapy. It was mostly done in group. And I still think the value of the milieu in having support staff that really can intervene and from a number of perspectives is far more, not far more, but every bit as important as that individual counseling process. So let's go to the next slide. And so here's our model, and I'm trying to figure out exactly how much time I have left. So if someone could just type that into the chat so I can know where I'm at. So, you know, it doesn't need to be expensive. It doesn't need to be labor intensive. It needs to be clear. Okay, thank you. A lot of times people make the mistake of thinking that we're going to work on all these trauma memories. And again, the way we view it is, if someone can stay in treatment for an extended period of time with folks at our ranch, at our residential environment, we may actually be able to go in and process some trauma memory. But we really expect that to be the case as they're moving out. But we believe that therapy is successful if a client can begin to resolve some of those symptoms associated with the safety process, and then be willing to go to treatment in other environments. So, and clients will often say, well, when are we going to work on the trauma? And we say, you've been working on the trauma since the day you got here. And that, you know, I will, I explain that to them on a regular basis. The next slide. So we have come to really understand that in order to be trauma integrated, we need to be gender responsive. And so the very most important part of this entire slide is in the blue box at the bottom. Both men and women experience mixed gender treatment as a less safe environment to work on both trauma and addiction. Additionally, recovery prerequisites associated with fellowship and connection can be compromised by traditional gender roles, relationship patterns when genders are combined. And when I got to the Foundry 3 years ago, a little over 3 years, 3.5 years ago, we were treating men and women together. And if you look at the slide, you can see that from the 50s to the present, we have gone through various sort of philosophical shifts. The original model in the 50s was developed by men for men, to be quite honest. In the 70s and 80s, with the women's movement and other kind of social movements, we began to recognize that we need to be more inclusive in the treatment that we provide. Stephanie Covington was a big player in this. In the 90s and 2000s, we really began to develop gender-separate programs. And we did it with the idea that women are traumatized, which really is amazing. And that we kind of forgot. We forget the fact that PTSD did not exist as a diagnosis until 1980. And prior to that, it was post-Vietnam syndrome or post-rape syndrome. And so the treatment world kind of made this separation so that women could work on their issues without having men being present. And then as Dan Griffin did his work with men, and we really began to look at the fact that men and women are both traumatized. Gender socialization is different for both. Help seeking is different for both. Recovery efforts need to be different for both. And so this idea, and also the cultural humility piece. And so can it be done in gender mixed groups? Well, it can. You're not going to be able to work at the depth that you would be able to work at in gender separate programs. We found that the biggest obstacle was not in the clinical activities, because we had men's groups and women's groups initially for certain topics, but it was in the evening when they were just sort of hanging around in free time that people would begin to act out, or trauma symptoms would begin to emerge. And so that's why we made that decision. So next slide, please. So this is Herman. These are the 3 phases of trauma treatment. Safety starts with control of the body, management of hyperarousal, cessation of dangerous coping behaviors, self-harm, management of intrusive symptoms, begin to reestablish trust, relationships, and attunement. That is, it's a developmental model. If they don't get that, then we're not going to go to mourning and remembrance, where they're actually telling their stories in their entirety in great detail and in great depth. And so I'll show you a slide in a minute that the hyperarousal isn't always from trauma. In many cases, it's shame-based from working on their addiction. And so we'll kind of show that. And then the last one is reconnecting with the community. And so if we go to the next slide, this book, I would recommend that anyone who's interested in developing a trauma integrated addiction program buy this book. Larry Heller and Aline LaPierre they worked with Peter Levine. It's really based in somatic psychotherapy. And the thing that really struck me when I read the book was everything they talked about: building current connection to the body, emotions, regulation of the autonomic nervous system, connection of mind, body, and behavior, were exactly the things that every addicted client that I've ever worked with needed. And so I found the work that Heller and LaPierre proposed to be appropriate whether someone had trauma or not. You know, we did research when I was at Cedar, and we found that 30% of our clients had post-traumatic stress disorder. And that probably another 30 to 40 had developmental trauma. And so I'm a firm believer that like codependency is really just developmental trauma. Codependency is the relational kind of acting out of developmental trauma. And so if we go to the next slide and look at the core needs on the left side of this slide are the needs of every client I've ever worked with addiction or trauma: connection to self or others, attunement to getting their needs met, trust, trusting self and trusting others, autonomy, the ability to set appropriate boundaries, to live a boundaried, healthy life. And then the last one is love and sex, the idea of if I grew up in an environment where I never learned those first four, then I tend to develop relationships that are about appearances and looking good, and rather than intimacy. And so I started thinking about my clients that I've had over the years that had kind of avoidant attachment, that really struggled to connect. And they would go to AA. They had great intention of staying sober. But when it came to the fellowship of AA, which I think is the most important, AA, NACA, all of those things, that I think are the primary clinical or the healing process is the fellowship, that they would relapse not because they wanted to use, but because they didn't develop these 5 core needs. And so connection, attunement, trust, and autonomy are what we have built our clinical model around. Connection to self, connection to peers, connection to our staff, and then connection to folks in the community who are sponsors and 12-step members. Attunement to needs. Most clients, when you ask them what their needs are, they have no idea. And so we have to teach them needs. And if they grew up in an environment where other people's needs always took precedence, it was really imperative. So, I use that model as our primary fundamental organizing model because of those 5 things. If we can skip the next slide and go. So this is our model. It's the lens that we look through to understand client behaviors. We see it as a 3-phase or 3 primary major points: attachment and differentiation. Traumatic stress symptoms are at the foundation, meaning those are the things that we believe will get in the way of someone working on the substance abuse issues. And then we put the NARM principles of connection, attachment, trust, and autonomy within there to say, as we're working in each of these areas, we're really working on those 5 things. And it's our belief that if we can get our clients, whether it's PTSD, whether it's developmental trauma, to work on those safety issues and to make the connection between those 5 things, that we're actually setting that person up to be able to leave our environment, engage in ongoing addiction treatment, but then move into working on the trauma memories as appropriate. So the next slide. So this is a model by a guy by the name of Eric Waltersdorf. And we use this quite a bit. The clients call it the marbles model. And the idea that if you look at the green line going across the middle of the page, that the more perceived threat that a person experiences, the more it activates the sympathetic nervous system, from relaxed to a stressed state to a strongly stressed state. And you can see the symptoms on the right-hand side of this model. And that, at the point in a traumatic event at which the person has no solution, he's tried or she has tried everything in their process to get out of it, that the sympathetic nervous system becomes overwhelmed, and the parasympathetic nervous system activates, and the person begins the process of dissociating. And so it's important, if we're going to begin to help clients manage their autonomic nervous system, that we have certain tools that they can begin to recognize and put the pieces together from being stressed and what that feels like from a body perspective to strongly stressed to dissociated. And so that's one of the things that we spend a lot of time with, and see that as really the foundation of the safety process. And if we go to the next slide, let's go. And so from a time perspective, the reason this slide is really important are the blue little circles at the top. In that trauma memories are remembered different than any other kinds of memories. And that when that sympathetic to parasympathetic process happens, the amygdala begins to assess that level of danger, and it shuts down communication with the hippocampus, that idea of beginning the process of establishing cognitive schemas. The Broca area of the brain goes offline, so language is shut down. Prefrontal cortex, the blood is rushing out of that, and so that the person is being overcome by the activation of the sympathetic and then parasympathetic nervous system. And the reason that's so important is it is the sensory information that is coming in during that traumatic event that is going to be remembered. And so we talk about trauma memory being timeless, and that when we experience sensory experience that is similar to what was experienced during the traumatic event, that we have a trauma experience or trauma memory. And so the reason that we have this slide with the previous slide is so often it is that sensory information that is being experienced as the advancement of that green line and the threat, because it's activating a trauma memory. And if we go to 2 more slides past this, if we look at the recovery milestones that a client has to go through, has to kind of come to terms with in order to achieve a willingness to engage in treatment, acceptance of powerlessness, and acceptance of a chronic disease, and surrender, and being rigorously honest, the more clients talk about addiction-specific issues, it activates the exact same process. And so this idea of, is it trauma or is it, it's threat? And at that point, if a person can understand how that model works, and if we go to the next slide, let's skip that slide and go to the next slide. These are the slides that I have on my office wall. And again, as I begin to see a client activate with trauma symptoms because they are experiencing threat, whether it's from working on step 1 and I don't want to be powerless. Think about it. If I have chronic childhood trauma, I've probably told myself at some level that I'm never going to, when I'm an adult, I'm never going to be powerless again. And I'm going to be hypervigilant. I'm going to be controlling. I'm going to manage my life in a way that I don't have to experience that level of powerlessness again. And then they show up at our facility and we start talking about step 1 and powerlessness. And we've now sent them into a relatively chronic somatic experience. And so to be able to put these 2 slides, and I am happy to send you a JPEG of this picture that you could make a poster to put in your office. But this idea of making the connection of where those marbles are in the somatic experience and putting together the thoughts that they're having at that point, emotions they're having at that point, body sensations and impulses, is really the work of trauma integrated work. Whether we're working on all of the people that the client hurt in their addiction, or whether they're dealing with the memory of not getting their needs met, the response is very much the same and very similar. So I hope that makes sense. So if we can go to the next slide, and this will be my last slide. So there's a process in somatic experiencing, it's called pendulation, to where you go between, you start working on an issue or you start working on a memory, and then as the body begins to activate the fight-flight response, that you take the person out of working on what they were working on, come out and use grounding skills, resourcing skills to bring the autonomic nervous system back into balance. And then you go back and start telling that story again. And so in our model, on the left-hand side of this slide are the things that we think clients need to achieve in order to maintain sobriety and to be able to move into the next phases of treatment. The things on the right-hand side are the things that we believe are imperative for a person to leave treatment and to be able to engage in a process of recovery, not just sobriety, but recovery. And so as a client is working on their addiction and they experience dysregulation, we pendulate out and work on regulation skills and then regulate and then pendulate back. The problem in my mind that most most addiction counselors make is they pendulate out to work on the dysregulation, but they don't ever get back to working on what was it that was so threatening to you about your addiction. And a lot of times it's grief and loss, and it's hurting family and hurting wives and kids and all of those other things, partners and all that. So I hope that makes sense. Any questions that you have, please ask. If you want, let's go to the last slide with my information. If you want any of the information, I'll send you the slides. I have a more extensive set of slides that I can send. I can send you the compassion fatigue information if you're interested.
Yeah, that'd be great, Dr. Barnes. And yeah, we'll also include that on the Supar seminar website too. You mentioned the compassion fatigue video, the family video, and then your presentation as well. If you want to send me a more thorough presentation, that'd be great too. And we'll provide links to your site as well. So
that'd be great.
Yeah, thank you very much, Steamboat, and the Foundry. We're very fortunate to have you here. So thank you.
Well, thank you. It's great to be here.
So any questions, type them into the Q&A box if you have any. Give it a second to let people do that if they have any.
It's always so much material.
Yeah,
so,
for sure.
Apologize for that.
No, you're fine. Hey, I got one for you. Up here in Northwest Colorado, what are you guys dealing with challenges, recruiting challenges in finding talent to join your team at the Foundry?
Yeah.
What are we lacking here? What sort of qualifications? What sort of people?
Well, first and foremost, I mean, the vast majority of our staff that we hire, we're not working in any behavioral health, other than the nurses and therapists. But most of our techs, certainly, folks in our kitchens and those things have never really worked in behavioral health settings before. And so they don't really understand confidentiality. They don't understand boundaries, other than, from very personal relationships or other work relationships. And so there's some good news that Colorado Mountain College is going to begin a process of offering CAC classes, Certified Addiction Professional classes, hopefully next academic year. And they've asked me to be on an advisory board for that. So we're really trying to begin the process of building a workforce that really understands the addiction process, the recovery process. Yeah, I think it's the biggest issue. And the other thing, everyone thinks it's awesome to live in the mountains until they live in the mountains and it's -12 for 12 days in a row or something. And so what we find is a lot of staff who want to come up and work at the last minute decide it's just too much of a change. And so we would really like to build a network of kind of homegrown staff that can work for you all, that can work for us. Providence. Now there's probably only 3 Cat 2s in all of Broward County.
Yeah, for sure. That is a definite issue that we're dealing with as well. So that's great news about Colorado Mountain College offering those classes coming up. Let us know if we can help out with that at all.
Yeah, I think what they're going to do is they're going to try to pull all of us as providers together and talk about what our needs are before moving too far or fast in that process. So we'll give you a call.
Cool.
For sure.
And then we got a quick question here, and then we'll move on to the next presentation. Does insurance cover the Foundry services, specifically Medicaid? If not, what's the average cost for inpatient services?
So insurance does cover. We're in network with 5 different insurance companies. We are not in network with Medicaid, and Medicaid is in the process of really making some changes regarding residential treatment. They've never paid for residential treatment until recently. And the average cost is, I'm trying to think, it's somewhere around $1,000 a day. And so again, there are variable lengths of stay, and with the, at least that's what the billing for insurance would be. We do work with people.
Right. And I'm sure there's going to be some more news coming in the pipeline here about Medicaid's coverage of inpatient. So we'll be curious to definitely know how that's impacting you guys as well as other facilities in Colorado. So, all right. Thanks, Dr. Barnes.
Thanks for the invitation. I appreciate it.
Yep. Have a good day.